Hello students, today's topic is pathophysiology of tuberculosis. Now firstly starting with the definition of tuberculosis, it is nothing but it's a potential fatal contagious disease which is affecting the whole body, but the main infection is there in the lungs, and it is coming from a neo-Latin word which is tubercle plus osis. Tubercle means round nodule or swelling and osis means condition. The causative microorganism responsible for the tuberculosis. So it is the Mycobacterium tuberculosis which causes tuberculosis in human, and another species of Mycobacterium, that is Mycobacterium bovis, which causes tuberculosis in animals. Other causative microorganisms, that is mycobacteria, are also present, which include Mycobacterium africanum, Mycobacterium microti, and also there are non-mycobacterial genus which includes Mycobacterium leprae, Mycobacterium avium, Mycobacterium asiaticum. But there are few bacteria which all come together to form a Mycobacterium tuberculosis complex. So which are those? They include Mycobacterium africanum, Mycobacterium bovis, Mycobacterium caneti and Mycobacterium microti. So all these together form a severe form of the tuberculosis which is caused by Mycobacterium tuberculosis complex. Now coming on to the characteristic features of the mycobacteria. So mycobacteria are specialized type of bacteria. They are gram-positive in nature. They are obligate aerobes or aerobic in nature. They are non-spore forming bacteria, and they are non-motile rod-shaped bacteria, and they are mesophiles. Their size is 0.2 to 0.6 into 2 to 4 micrometer square. Its generation time is slow, that is it takes 15 to 20 hours, and it may contribute to the virulence. Lipid-rich cell wall contains mycolic acid. Mycolic acid is special type of acid which is present in the mycobacterial cell, which form the 50% of the cellular wall or wall dry weight. It is responsible for various bacterial characteristic properties. So it is a acid-fast bacteria and it stains with the acid stain, and it also gives resistance to the detergent and antibacterial. So normal bacterials are killed by either detergents or the antibacterial drugs, but mycobacteria consist of a special type of substance called as mycolic acid in their cell wall, which provides a protection against the detergents and antibacterials, and it is responsible for characteristic properties of the mycobacterium. Next is the classification of tuberculosis. So tuberculosis basically can be classified into pulmonary tuberculosis and extrapulmonary tuberculosis. Pulmonary, the name itself indicates, it is the tuberculosis which is associated with the lungs, that is pulmonary tuberculosis. Then extrapulmonary tuberculosis, it is the tuberculosis which is associated with the other organs other than the respiratory system. So when the tuberculosis occurs in the organs other than the respiratory system, then it is called as extrapulmonary tuberculosis. So it includes lymph node tuberculosis, pleural tuberculosis, tuberculosis of upper airways, tuberculosis of skeletal system, genitourinary tuberculosis, miliary tuberculosis, pericardial tuberculosis, gastrointestinal tuberculosis, tuberculosis meningitis, and other less common forms. So these are the two basic classes and subclasses of the tuberculosis. This is the epidemiology, wherein dark red color indicates more amount of the severity of the tuberculosis in the different countries. So the India is also coming into that, which is affected. So in the map you can see the different countries which are affected to what extent. In 2011, there were estimated more than 8.7 million incidence cases of tuberculosis globally. So this was the year wherein highest number of cases were seen, and it's equivalent to 125 cases in 1 lakh population. and in Asia it is found to be 59%, Africa it is 26%, Mediterranean region 7.7%, European region 5.3%, and region of America constitutes 3% of the cases. So India is the highest TB burden country, accounting for more than 1/5 of the global incidence. So our country India is mostly affected by the tuberculosis. So global annual incidence, that is, if we see the incidence of tuberculosis in the whole world, it is 9.4 million, but in individually India only it is 1.96 millions. So here in this pie chart you can see the different countries, how much they are affected. The highest one which is affected is 21%, which is India, followed by China, then followed by the Indonesia, Nigeria, South Africa, Bangladesh, Ethiopia, Pakistan, and Philippines. So this gives an idea how much it is spread into the India. So this is again another graph wherein age group wise incidence of the tuberculosis is shown. So it is less in the case of children belonging to age 5 to 14 years. It is slightly more in the case of the age group for 15 to 34. It is slightly more than that in the age group 35 to 54, but it is highest in the case of elderly people having the age 55 plus. Then number of deaths as compared to the other kind of infection, if you see here, so here it is indicated that tuberculosis is showing more number of deaths as compared to the other infections like HIV, measles, sexually transmitted disease, malaria, and tropical disease. So here you can see that tuberculosis is causing more number of deaths as compared to the other infections. Spread of tuberculosis, how the tuberculosis is spread from a diseased person to the healthy person. So if a person is having tuberculosis and he or she is coughing without the covering of mouth, without using mask, and if that person is sitting in a crowded place with poor ventilation, and if the person is spitting everywhere, then the bacteria which is present in the person's sputum or cough, that will be easily spread in the form of the nasal droplets, or in the form of the sputum, or in the form of the airways. So in all these things, by all these modes, the tuberculosis bacteria is spread from a diseased person to the healthy person. Now the signs and symptoms. The symptoms which are severe one include persistent cough. So the person can have cough for more than 3 weeks, continuous coughing is there. Chest pain is there because of the coughing with bloody sputum. So the sputum which is coming after coughing consists of blood. There is a shortness of breath, urine discoloration, that is abnormal coloration of urine is there, cloudy and reddish urine is there, fever with chills and fatigues. So these are the severe signs and symptoms of tuberculosis. So based upon the type of tuberculosis, there are several sites and several signs and symptoms which are associated with that. So if it is a pulmonary tuberculosis, then it is causing severe weakness, fever, weight loss, productive cough, night sweats, etc. But if it is primary pulmonary tuberculosis, then there are some structural abnormalities which are occurring. Then tuberculous pleuritis, that is in the lungs, that is outer structure of the lungs, it leads to the chest pain, dry cough, and return of dormant tuberculosis, that is cough with increased mucus or coughing up the blood. Then extrapulmonary, that is the sites other than the respiratory tract. So common sites are meninges, lymph nodes, bones and joints, genitourinary tract. So these are the mostly affected ones by the tubercular bacteria or Mycobacterium tuberculosis. So this is miliary tuberculosis, which is severe form of the tuberculosis, which is causing several severe signs and symptoms. So steps involved in the pathogenesis of the tuberculosis. So whenever there is exposure of the source, exposure to the source, or if a person is infected with the tubercular and mycobacterium tuberculosis, and if he is suffering from the tuberculosis, then if that person spread the aerosols or the air droplets of this tubercular bacteria, and that is inhaled by the normal or healthy person. So after exposure to that particular microorganism, there is aerosolization of the droplet nuclei. That is, while coughing, there are droplets which are formed in a very small size, and that leads to inhalation of the bacteria into the respiratory system. So most of them do not show any kind of infection, that is more than 50% of the people, but 25 to 50% of the people, in this the bacteria reach the lungs, they enter the macrophages, and once they enter the macrophages, bacteria start multiplying in the macrophages. So here you can see these are the macrophages, and the bacteria are invading into these. Bacteria multiply into these macrophages, and they form a granulomatous lesions which begins to form, which is of type caseous necrosis. Then bacteria cease to grow, that is stoppage of bacteria to grow. Lesion calcifies, so 90% of the lesions are calcified, and they cause immune suppression. Reactivation can also take place, which is further leading to increased bacterial count. Then in caseous necrosis, lesion causes liquefaction, and bacteria is cuffed into the sputum, spread to the blood or the other organs, and if it is left untreated, it will lead to the death. So this is the pathophysiology of tuberculosis, how it spreads into our body. Now talking about the types of tuberculosis. So already we have discussed there are two major types of tuberculosis, that is primary tuberculosis and secondary tuberculosis. So earlier we have seen the pulmonary and extrapulmonary. Now dependent on the etiological factors, we have primary tuberculosis and secondary tuberculosis. So primary tuberculosis, in which the individual who has not been previously infected or immunized, then he gets the tuberculosis, it's called as primary tuberculosis, also known as Gons complex or childhood tuberculosis. Lesion forming after the infection is in the peripheral region and accompanied by the hilar, which may not be detectable on the chest radiography. Then secondary tuberculosis is there, in which the infection, that individual has been previously infected or sensitized, so that is secondary tuberculosis, wherein the person already is exposed to that particular tubercular agent and he has got the tuberculosis earlier. So it is also known as post primary or reinfection or chronic tuberculosis. So after pulmonary and extrapulmonary, the next classification is dependent on the etiological factors, so that is primary tuberculosis and secondary tuberculosis. Next is extrapulmonary tuberculosis. So here pulmonary tuberculosis can be divided into primary tuberculosis and secondary tuberculosis. Extrapulmonary tuberculosis, that is a tuberculosis other than the respiratory system. So 20% of the patients of the tuberculosis patients are suffering from extrapulmonary tuberculosis. There are several sites in our body which are affected, which include lymph node, which is also known as tuberculous lymphadenitis. It is seen frequently in HIV infected patients. Symptoms include painless swelling of the lymph node, commonly the cervical and supraclavicle lymph node. Systemic systems are limited to HIV infection patients. So the body organs which are having systemic blood flow are limited to the HIV infected patients. So those patients who are already having HIV, they are having more chances of getting the tuberculosis. They are highly prone to the tuberculosis. So in the lymph node tuberculosis, there is painless swelling of the lymph node, especially in the cervical lymph node and supraclavicle lymph node. Next is pleural tuberculosis. It consists of involvement of the pleural cavity, which is surrounding the lungs, and is common in the primary tuberculosis, and it results from penetration of tubercular bacteria into the pleural cavity or pleural space. So that's why the name is given as plural tuberculosis. Tuberculosis are of upper airways. These include larynx, pharynx, epiglottis, etc. Signs and symptoms include dysphagia, chronic productive cough. Then comes the genitourinary tuberculosis. So here 15% of the extra pulmonary cases are there. Any part of the genitourinary tract can get infected. So as the genitourinary is involved, it consists of all the genitourinary tract organs. Signs and symptoms include increased urinary frequency, dysuria, and hematuria. Increased urinary frequency, that is, the person urinates for more frequent times. Dysuria is difficulty in urination. Hematuria means presence of blood into the urine. Then skeletal tuberculosis, it is associated with the skeletal muscles and bones. So there is involvement of weight bearing parts like spine, hip, and knee. Symptoms include pain in the hip joints and knees, swelling of the knees, and trauma. This is because of tubercular infections in the skeletal system. Then gastrointestinal tuberculosis, the name itself indicates it is associated with the gastrointestinal tract, or there is involvement of gastrointestinal tract, that is any part of it. Signs and symptoms include the abdominal pain, diarrhea, as well as weight loss. So we have the different types of extrapulmonary tuberculosis, including lymph node tuberculosis, pleural tuberculosis, tuberculosis of upper airway, genitourinary tuberculosis, skeletal tuberculosis, and gastrointestinal tuberculosis. Next is meningitis, tuberculosis, and tuberculoma. So 5% of all extrapulmonary tuberculosis result from hematogenous spread of first degree and second degree tuberculosis. So tuberculosis is a basic infection which is affecting the respiratory tract, but primary and secondary tuberculosis, they are helpful in spreading of the tuberculosis into the different organs, forming extrapulmonary tuberculosis. Then other type of tuberculosis, extrapulmonary tuberculosis, is pericarditis tuberculosis. That is the tuberculosis which involves the inflammation of pericardium. So 1 to 8% of all extrapulmonary tuberculosis cases are there. It spreads mainly into the mediastinal cavity, that is near the heart, and hilar nodes from the lungs. Miliary or disseminated tuberculosis, this results from hematogenous spread of tubercle bacilli. Spread is due to entry of the infection into the pulmonary vein, which is producing lesions in different extrapulmonary sites. Less common extrapulmonary tuberculosis, it consists of uveitis, then panophthalmitis, painful hypersensitivity related reactions, and filicentrular conjunctivitis. So these are the different infections which are associated with the extrapulmonary tuberculosis. Next comes the diagnostic measures or diagnostic process. So firstly we go for the testing the presence of the bacteria, that is tubercular bacteria. So bacteriological stain is done. So as the Mycobacterium tuberculosis is acid fast bacteria, it stains with the acidic stain. Hence we apply Ziehl-Neelsen staining, which is specific for the Mycobacterium, which is staining the mycolic acid. Next is auramine or fluorescein stain, which is used for fluorescence microscopy. Then sputum culture test. So in this, the sputum is collected and it is cultured for into solid medium for 4 to 18 weeks, liquid medium for 8 to 14 days, and agar medium for 7 to 14 days, wherein the mycobacterium will grow and develop, and we get an idea that whether the person is suffering from tuberculosis or not. Next is radiography or chest x-ray. So here you can find the chest x-ray of healthy patient and chest x-ray of the tuberculosis patient, which shows the infection. Then there is nucleic acid amplification. So that is associated, or that is helping us in identification of the species. That is, a nucleic acid of the causative microorganism is amplified. It takes several hours, but it is having low sensitivity, it is costing more, and it is most useful for rapid confirmation of tuberculosis in the persons. Then AFB negative pulmonary tuberculosis. So here sometimes the acid fast staining is negative, but still the pulmonary tuberculosis is there, and extrapulmonary, and that can be found out by nucleic acid amplification. Extrapulmonary tuberculosis also can be diagnosed by nucleic acid amplification. Next is tuberculin test. So in this test, this is to check whether the person is suffering from tuberculosis or not. We need to inject a fluid into the skin of the lower arm, and 48 to 72 hours later it is checked for a reaction. A diagnosis is based on the size of the wheal. So if the person is suffering from the mycobacterium tuberculosis, then he gives the following reactions. So dependent on the formation of the wheal which is there, that is the circular shaped red color structure because of injection of the mycobacterium, life attenuated. So if the diameter of that particular lesion or wheal is less than 6 mm, then interpretation is negative, and previously unvaccinated individual may be given BCG vaccine provided there are no contraindications. Then if the wheal size is 6 mm or greater but less than 15 mm, then hypersensitivity to tuberculin protein is confirmed, which may be due to previous tuberculosis infection, BCG or exposure to atypical mycobacteria. Action here, BCG vaccine should not be given. If the diameter of the wheal is greater than 15 mm, then the person is strongly hypersensitive to tuberculin protein and it suggests the tubercular infection or disease. So here in this case BCG should not be given and further investigation has to be carried out, and the proper drug treatment with anti-tubercular drug should be given. Pathogenesis of tuberculin test, that is how the tuberculin test gives us the result. So tuberculin test is a type 4 hypersensitivity reactions. So here is the antigen which is injected. So T lymphocytes attack these antigens and there is cytokine secretion. Cytokine secretion leads to the macrophage recruitment and polymorphonuclear leukocytes into this particular antigen, and that leads to cellular infiltration, swelling, which is leading to the inflammation or formation of wheals. Other biological examinations include cell count, that is lymphocyte count, protein count, that is to check the ascites, that is accumulation of fluid in the abdominal cavity, pleural effusion, that is the accumulation of fluid in the respiratory tract or pleural cavity, and meningitis. So these other signs and symptoms are also seen along with the tuberculosis. Next is the preventive measures. The person who is suffering from any kind of respiratory disorder including tuberculosis must wear a mask so as to prevent the droplet infections to the others. BCG vaccine is very important, which is given in the childhood only. Then it is preventing the mycobacterium tuberculosis infection. Then regular medical checkup or follow-up is required. The person has to be isolated from others to avoid contamination or spread of infection. Ventilation is required, proper ventilation is required so that the person can breathe properly. Natural sunlight and UV germicidal irradiation is required so that the mycobacterium are not spread to the other person. So prevention, for this we need to have personal hygiene. Immunization in the childhood itself is required. Healthy lifestyle and environment is required. So BCG vaccine, it is named as Bacilli calmette guarin, which stands for BCG. It was first used in 1920. So only vaccine which is available today for protection against the tuberculosis. It is most effective in protecting the children from the disease. So it is given 0.1 ml intradermally and duration of protection is 15 to 20 years and efficacy is up to 0 to 80%, and it should be given to all healthy infants as soon as possible after the birth unless the child presents with the symptomatic HIV infections. Management or treatment. So there are two types of drugs which are used for the treatment of tuberculosis. One is the first line drugs. First line drugs are the compulsorily used drugs in the drug therapy. Second line drugs are those drugs which are used as an adjuvant with the first line drugs. So first line drugs include isoniazid, rifampicin, rifampicin, rifabutin, ethambutol and pyrazinamide, while second line drugs include cycloserine, ethionamide, levofloxacin, moxifloxacin, gatifloxacin, paramylosalicylate acid, streptomycin, amikacin, kanamycin, capreomycin, etc. Now dosage regimen, that is how these essential or non-essential, or what we can say, the first line and second line drugs can be combined together. So first dosage regimen is intensive phase plus continuation phase, and second is HREG regimen for 2 months followed by HRE for 4 months. So these are the recommended dosage for initial treatment of tuberculosis in the adults. So isoniazid, rifampicin, pyrazinamide and ethambutol, these are the first line drugs which are used. So daily dose for isoniazid is 5 mg per kg, maximum 300 mg. Rifampicin 10 mg per kg, maximum 300 mg, 600 mg. Pyrazinamide 20 to 25 milligram per kg, maximum 2 grams can be given. Then 15 to 20 milligram per kg of ethambutanol. So this is the daily dose which is given. Then thrice week dose, that is 15 milligram per kg, maximum 900 milligram for isoniazid, 10 mg per kg, maximum 600 mg per kg for rifampicin, 30 to 40 mg per kg and maximum 3 grams, and 25 to 30 mg per kg. So these are the thrice weekly doses which are needed to be followed. So according to the WHO, the 5 main drugs are there: isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin, which is HRZES. Then here you can see that at the initial phase and in continuous phase how the drug treatment are given. So in the case of new smear or culture positive cases, the isoniazid, rifampicin, ethambutol and the pyrazinamide are used. Continuation period is 4 months. Then the drugs involved are the rifampicin and isoniazid. Then new culture negative cases, in this duration of treatment is 2 months, HRZE drugs can be used and continuation is for 2 more months. Then in pregnancy it is given for 2 months time. The regimen is given for 2 months time. It consists of HR and E, that is the isoniazid, rifampicin and ethambutol, and it is continued till the phase of 7 years, 7 months. Then if there is failure or relapse, if the person suffering from tuberculosis again gets the tuberculosis, which is called as the relapse after the recovery. So the resistance for or intolerance for the isoniazid or H plus R, that is isoniazid and rifampicin, is developed throughout. Then a resistance to the pyrazinamide and rifampicin is occurring in 12 to 18 months. Then resistance to all first line drugs, that for that regimen is used throughout the 24 months, and in that case the pyrazinamide, ethambutol and other drugs can be used. Then standardized treatment 3 months, as well as the treatment with HRZES, that is all the 5 drugs. Then drug intolerance, in that case HZE can be used, and drug intolerance to Z, that is HRE can be used. So these are the different drugs which are used in the combinations for the treatment of tuberculosis. Dots is directly observed treatment, which is a short course therapy. So dot means that the trained health worker on other designated individual provides the prescribed tuberculosis drugs and watches the patient swallow every dose. So here the person is observed whether the person is taking the treatment or not. So multi-drug resistance tuberculosis. So some sort of or some form of the tuberculosis are resistance towards the different microbial agents or the drugs which are used against the tuberculosis, anti-tubercular drugs. So those drugs are the mycobacterium produce resistance towards those drugs also, so wherein multiple drugs are involved. So tuberculosis is caused by strains of mycobacterium tuberculosis that are resistant to at least isoniazid, rifampicin and anti-tubercular drugs. So after sometimes they become resistance, that is even if the dose of isoniazid and rifampicin is enhanced, they won't be getting killed. Globally 3.6% are estimated to have the multi-drug resistance tuberculosis, in which the different drugs which are mentioned here, that is isoniazid, rifampicin and all, they have to be given. So here globally the 5% of MDR tuberculosis, that is multiple drug resistance tuberculosis, is observed, wherein the tuberculosis is developed or the species becomes resistant towards the all drugs. So here 50% of these cases are observed in the worldwide and occurring mostly in China and India. Next is extensively drug resistance tuberculosis. So it is more severe form of drug resistance, which is called as XDR-TB, extensively drug resistance TB. It is a form of tuberculosis caused by bacteria which are resistant to isoniazid and rifampicin, and as well as any fluoroquinolone kind of drug or any other second line tuberculosis injectable drugs, including amikacin, kanamycin and capreomycin. So sometimes the bacteria may become resistant towards the different drugs, which is called as extensively drug resistant tuberculosis. Next is tuberculosis and HIV. The name of these two diseases are taken together because the HIV patients who are immunocompromised, they are likely to have this disease, or they are having higher chances, or they are highly prone to this tuberculosis because of their immunocompromised conditions. So worldwide there are number of people who are suffering, who are infected with both HIV and TB, which is rising a lot. Then HIV virus damages body's immune system, the person becomes immunocompromised, and the person may get affected with the tuberculosis, and it progresses. Then estimated 10% of activation of dormant tuberculosis infection over the lifespan of infected person is increased up to 10% in 1 year. HIV infection is superimposed. It is the opportunistic infection that can mostly frequently kill the HIV positive people. So there is a very important relationship between tuberculosis and HIV, because HIV patient with the immunocompromised condition can have any infection including tuberculosis. Then epidemiological impact, so reactivation of latent infection. So people who are infected with HIV and TB are 25 to 30 times more likely to develop tuberculosis again than the people only infected with tuberculosis. So HIV, the person having HIV and tuberculosis are more affected as compared to the person having only tuberculosis. Then primary infection. So newer tubercular infection is in people with HIV can progress to active disease very quickly. Recurring infection, it is occurring in the people who are cured of tuberculosis. So again and again the infection can be repeated in those patients. Diagnosis of tuberculosis in patients with HIV. So HIV positive people with the pulmonary tuberculosis may have higher frequency of having sputum negative smears. So sputum may show negative results, the tuberculin test often fails to work because the immune system has been damaged or compromised by HIV. So these two tests are not useful in the case of HIV plus TB. It may not even show a response even though the person is infected with the tuberculosis. Then chest X-ray is again to see whether the infection is there in the lungs, and extrapulmonary tuberculosis cases are also very common. Yes, so this is all about the tuberculosis, its pathophysiology, the microorganism responsible, signs and symptoms, treatment, different kinds of drug regimens. Thank you so much.